Okay, so picking up where we left off, we are on the artifacts that can be seen or that you can have with flat panel. So the first one was the dead pixels. Now we're going into the incorrect gain calibration. So gain calibration is used to correct flaws in the detector. So if an area of the detector has a large amount of dead pixels, or if there's an area of the detector that has poor connections between the conversion layer and the ASI TFT array, a noticeable artifact can be seen on the screen. So to remove the potential of having that artifact interface with the diagnosis, the process is known as gain calibration or flap field occurs. So that's kind of weird how that's stated. So it's called gain calibration. So this process will remove these densities on the image by creating a mask of those defects. When a subsequent image is taken, the software will use only the mask to remove the unwanted densities and leave the diagnostic information there. So here is the your photo cells, so you can see that that would be a problem. So gain calibration should be performed under the same or similar circumstances in which the clinical images will be taken. So the calibration should be according to the equipment manufacturer's guidelines. So looking at 5.8, notice the AEC cells, so you can see those here. So you can see the AEC cells right there that appear, they're slightly positive squares on the image. So the gain calibration was performed with the detectors outside of the bucky, and then a subsequent image was taken with the detector in the bucky. This could happen if anything is left on the detector during the gain calibration. So these faint marks could lead to a misdiagnosis. So image lag and incorrect offset correction. So some flat panel systems have the ability to take images faster than the detector can accommodate. If an image is taken before the detector releases all of the signal from the previous image, a faint image of the previous exposure may be visible on your new exposure. So this is called image lag. So image lag is almost like a double exposure. So you'll see your prior image along with your current image. So when the detector is unable to eliminate all of the signal from the previous image, lag can occur. So some of the reasons are rapid succession of images is only one reason for the lag. Another reason is for image lag might occur if overexposure of an area with little beam attenuation, such as the technologist lead marker. So you'll see in the image coming up that the lead marker is still there from the prior image. So you can see the right marker, that we don't ever use a right. We know it's incorrect, and if you were to look at the image that was taken prior to this, you would know that that was from your prior image. All right, so to reduce the possibility of image lag, so you increase the amount of time between exposures, giving the detector sufficient time to release all the residual image. Consult the operator's manual, of course, for suggested interval times. But if you take images back to back to back to back, especially if you use the highest dose first, you can have this. So another way is reduce the amount of unattenuated beam by collimating as much as possible. So you want to collimate as close as you can. You want to set the appropriate technical factors for each body part being examined. So if multiple examinations are being done, you want to acquire the image requiring the highest technical factors last, not first, last, to make sure that the last image will have it, and you can do time in between the next patient. So image lag can also be corrected with the detector's software using the dark noise or offset correction. So offset correction determines the amount of signal inherent in the detector. If an offset correction is performed before residual signal leaves the pixel, that information will be stored as inherent and could cause a negative image on the residual signal. So always follow the equipment manufacturer's guidelines when performing any detector calibrations. For example, we'll show you another one. So in 510, an offset correction was performed after an exam was done with the right marker in an area of unattenuated radiation. So the residual signal remained in that area and a subsequent offset correction was performed. The R and is now viewed inversely because the signal created a mask during the offset correction. In figure 510, you also notice that the signal is still very strong, and this image was taken 10 minutes after the initial exposure. So you can see the R right there, so not good. Now I'm going to talk to you about emerging technologies. In conventional projection imaging in the past, the image technique was called tomography. So tomograms were required by attaching a fulcrum to the bucky and the tube head. So the bucky and the tube head would move in concert with one another, and the tube could arc across the patient. The fulcrum point would determine the area of the body image. So the same concept is now being used in digital imaging, and it's called tomosynthesis. So I'll show you what that looks like in the slide after this one. So tomosynthesis was previously possible because earlier digital detectors were not able to acquire images rapidly in succession. With advances in the selenium detectors and amorphous silicon TFT arrays, the detectors are now able to acquire images at a rate of 30 frames per second. After the acquisition of the entire set of frames required for the body part being imaged, the frames are sent to a post-processing workstation for reconstruction. So the images are then sent to the viewing station as a stack of images similar to the stack that we see on CT images. So the images can be viewed as a single slice or in a cone mode like in CT. So this is how it works. It has a fulcrum, so you can see here that the tube moves and we can see multiple images in your fulcrum. All right. So currently the most tomosynthesis is being done in breast imaging, primarily for patients with very dense breasts. There have been several studies done looking at the benefit of this type of imaging on extremities of the and the chest. As technology becomes more readily available, more applications will be put into use with this imaging modality. We used to use do tomograms in the chest and in the abdomen so we can see things better years ago. So I'm sure it'll come back. So here's the summary. So you're going to want to read the summary, make sure that you understand everything that I've talked about here today. You will also want to watch the image processing in your week 8. So that'll show you actually illustrations and live models on how all of this works. Okay?